All right. All right, so just a quick recap. We know this is a common problem. What we're looking for is good, healthy legs. We've talked about the venous pumps. We've talked about perforators that are important along the way. We're looking at venous hypertension coming from the valves and the perforators per se, and that we know that it's all underlying venous hypertension. Again, this is a foundational principle, but when we come to changes like this, from CEAP 4 to 6, we know that there's venous hypertension that has been going on for a long time and has now led to all these chronic changes. And how do we now treat this? There rarely is a straight GSV segment trying to actually treat this segment, which we've tried years before with direct needle puncture and ablation. We've had a case where it was severely infected, went all the way down to the bone, had all kinds of issues. We obviously create a map of the hypertension to see where the reflux is coming from, including the perforators. And then as we walk through the CEAP classification, we know now in this from 4 to 6, how do we really treat this? A lot of them will have perforators that are leaking in addition to the saphenofemoral junction, and really walk our way through that. So as we get through this now, looking at 5 and 6, with these wounds like this, we want to relieve their hypertension. Obviously, we plan the therapy, made sure we had detailed discussion with the patients. Our goal here is to heal the wound. All the conservative measures are in place. We're making sure there's wound care in place as well, and counsel them extensively. Compression therapy is a mainstay of this. We make sure they have adequate compression therapy, and now we've decided to intervene. We know we have laser, but if it's a straight segment, we can do it. Same with RF ablation. We've talked about phlebectomy, and here comes now the microfoam therapy, however you do it. Obviously here, I have seen a patient in our community that had foam therapy, and I think it was possibly an operator issue. She put a lot of it, got a massive embolus, and actually the patient died. So, there's one or two of those cases. If used judicially, obviously it's very good. But here now we have a patient that has extensive venous disease. This one case is, he had a wound, it's healed. He's been my patient for 8-9 years. He came back after a while, and now he had all these perforators and different branches, and we've treated him before, and these are the before and after pictures. Yeah, so here is the video case, so to show you how we've kind of worked our way through that. So we know that he has a large thigh perforator and a branch coming from the GSV. This is what it looked like as we started it. So we know that it's coming all the way down. He probably has a couple of other perforators as well. So there are 2 separate branches coming in. We basically first had him supine, got in the active, and you see when he lays down, it collapses. He's had earlier surgical procedures before. And now when I've laid him down, it kind of collapses. So I've kind of did a reverse Trendelenburg to make sure it dilates up as well. And then once I get into that segment, now I'm going to start putting the Varithena. Now at this point, I actually do a Trendelenburg to empty out the vein as much as possible. If we don't elevate it, they kind of get extensive coagulum, so I make sure we've emptied it out. You see the ultrasound, the veins up there, that's what I'm looking at. I've already got the butterfly. And this is a 20 gauge or 21 gauge, give a little lidocaine, get it secured well. Then I elevate the leg. Then when I inject, and you see that's, as Ron was describing, I'll get the foam to go into the perforator. What we don't want is this sitting in the deep veins. So at that point, I'll make him kind of pump that calf. allowed that to wash away. The other part of this that at least the company talks about is that it contains a lot of oxygen and carbon dioxide and very little nitrogen, so it dissolves in the blood. But as Ron showed, I make sure it goes into those branches. And you can see how with all this, because he's had previous treatments, there are all these kind of curlicue branches, nothing that you could do with thermal directly. And while I'm injecting at that point, I want to be extra cautious. Yes, they say nothing happens if it goes deep, but I compress that with the ultrasound. Then I make sure there's complete spasm of all those branches. I actually keep that leg elevated a good 10, 15 minutes. We put a wedge under that, a big foam wedge. We let it empty out, let the chemical act on the vein per se. So this is the result a week and a half. This was that medial branch, but you see the other one is still filling because it was filling from a different branch and not the same circuit. So the next time I brought him in, got him lower down, did the same thing similarly on him, and did the exact same procedure. Did the Varithena, compressed it. I encourage them first 48 hours not to take off the compression. Here's the result 4 weeks later on this side. I make sure that they have good compression. First 48 hours, don't take it out. I tell them have a shower with it, take a hair dryer, dry it if you want to. Then after that, they can wear it mainly when they're vertical. The reason I say that, I was a guy who used to work the night shift. So I told him, wear in the day, don't work at night. So he was sleeping all day and he wore compression. He was standing all night and he didn't wear any compression. So since then, I've kind of said that. Again, this was the last one where we got into that branch that was lower down and finished that. So, all right, we go to here's a CEAP 6 case now. Gentleman with a nasty, nasty wound. And he's had his saphenous vein ablated. He's got all that part taken care of. And but he still has this wound. We had some massive perforators lower down. And this is kind of not a good bet to stick a needle in it, but tumescent or, and we've had a case, as I was describing earlier, we got very badly infected, went all the way down his bone. So when I do the ultrasound underneath, you see there are these large vessels. And obviously there's a perforator filling that as well. And again, sterile, clean, needle in there. Pick this side, I can see that vein's fairly large right there. This is not amenable to laser or RF in any way for thermal. In the past, when we didn't have Varithena, we used kind of physician compounded foam, not a problem. So now we've got a 21 gauge butterfly. Sometimes if it's straight segment, I'll put an angiocath in. But here the skin is hard, and I don't want to take that chance of pushing something in. But you can see there's the butterfly, secured it. And then less is more for me. I make sure I'm not overdoing this. And take about 5 cc's of Varithena there. Then put it in that area, allow this to completely spaz out, so to speak, empty the vessel, raise the leg a little bit, make sure it's empty. And I get it up to the perforator. You see, there's the perforator. I'll make sure the foam comes up to there and I compress this spot. Because, there's enough debate. Ron doesn't care if it goes in. But if too much goes in, I have a complication, I can't defend myself. So I say, yeah, I've compressed the perforator. And then, especially with, the key goal here for me is that when I inject, I'm going to follow the foam and make sure that that vein is completely emptied out. So I kind of follow it with the ultrasound. And I'm watching it on the probe as well. So he had a perforator right up there. And as I'm following it, you see the blood being replaced by the foam. And then kind of right that part there. A little graphical representation to show what it's really doing. It's never as clean as this, but that's the concept. that we are actually allowing this foam to displace it. That's why I elevate the leg so gravity helps empty this out as well. You can obviously see there's edema in the tissue as well. I also make sure that I will kind of take the ultrasound and let it go into the branches, both cephalad and caudal, into the branches, so to speak. So this wound healed in 4 weeks. He had been going on for months with wound care on this particular situation, and it hadn't healed. Obviously, they need good wound care at the same time. One advice is not to stick a needle through an active wound, but you could do it through a hyperpigmented area or something like that, only because you can land up exacerbating the infection a little bit. You've heard a fair amount of this. We've had a focus on the newer technologies. We've had success with both, but I've not seen any complications with the microfoam. I have seen complications with the other one. Somebody just described to me a case just at the meeting today where they injected into a branch and now it's got femoral vein DVT with physician compounded foam. So it's that one case that can happen and now cause a problem for you. I agree that if you're very, very diligent and in making the foam, and you're doing it well, yes, you can get that. And if you're doing that, you want to make less is more. But to me, the safety of Varithena just oversees all of this. So now even CEAP 1 and 2, I mean, we have cans lying around and I have enough. And when I do saphenous and other branches, I let it go all into the other reticular branches. So it's a kind of bonus for the patient. They love the fact that they've had a good cosmetic appearance as well, and it works out. You already have seen some of this and heard about this. The key concept here is, and I tell this to my patients as well, there has not been one case in several thousand even in patients with the patent foramen ovale and looked with MR, that they've not had any complications, which is important. And you need that one patient to have that complication where they come into your office, you're doing some foam therapy, and all of a sudden they got a TIA or they can't see partially. It just is not good for your practice. And I don't know whether that's a risk I really want to take. And some may want to do it. And this is that study that I was talking about. You can see these bubbles migrate through, and you just don't want that. So it has a good safety profile, especially now that it's reimbursed, but you have to be careful on how you use it for the reimbursement purposes. If you use Varithena in a peripheral branch and it's not connected to the saphenous, it's not a branch of the saphenous and there's no saphenous insufficiency, you are using it just like sclerotherapy based on my understanding of the guidelines that CMS has. But if you have saphenous, greater or lesser, above or below, and then you have branches related to it, then yes, it's reimbursable for that. To me, this is the most important element, that it's very, very safe. I've done maybe several hundred now in the last 2, and so we've not had, touch wood, a single problem. We want to keep it that way. We talked about the reimbursement earlier, so we know we have decent reimbursement for this. Documentation is extremely important, so pictures before, during, and after. I showed you CEAP 2 and a CEAP 6. In the ones that have CEAP 2 and they have kind of telangiectasias, when I inject it with the ultrasound, I'll make sure the foam gets into all of those. But in my mind, compression following this, good compression therapy is the key for good results, number one. And number two, good follow-up so that as and when they get some coagulum in some spot, catch it early before it's very organized. Often just an 18-gauge needle, it releases it, pressure's gone. Tomorrow we have a live case of a patient who has, we're talking of as big as 35 and 40 millimeter veins. And now you'll see him tomorrow where it's completely treated with microfoam. And then one side with partial RF ablation and microfoam. Thank you.